Welcome to Essentials of Acute Care. I am Dr. Sunil Garg. In our series on shock, today in part 4, we will discuss initial diagnostic evaluation of shock patients. A high clinical suspicion for the presence of shock is critical for the diagnosis of shock. In my last video, I discussed about when to suspect shock, and hypotension is one of the important features. Here it is important to understand that hypotension and shock are not synonymous. Even patient can have hypotension without shock, and shock patient may be normotensive or hypertensive. General assessment include thorough history. History will not only guide in assessing the shock state or in diagnosing shock state, but it will also help in identifying the etiology. Other assessment include assessment of sensorium, assessment of mucous membrane, lips, tongue, neck veins, lungs, heart, abdomen, skin and joints. Look for hypotension, oliguria, mental status changes, and cool clammy skin. ECG should be done to look for ischemia, arrhythmia, pericardial effusion, or any finding of pulmonary embolism. And there should be an assessment for the etiology. Laboratory evaluation in the undifferentiated shock state include measurement of serum lactate. Measurement of serum lactate is particularly useful in those patients who are normotensive or hypertensive because these are the group where shock is less likely to be suspected. Serum lactate is the marker of poor tissue perfusion, though it is sensitive but not specific for the shock state, and it can be measured serially to look for response to therapy. Other investigations include renal and the liver function test, cardiac enzymes and the natriuretic peptides, complete blood count and differential count, coagulation studies and D-dimer level, and the blood gas analysis. Other lab evaluation which is directed towards specific etiologies may be done if required, and it includes urine analysis, urine sodium and creatinine for hypovolemia, toxicology screen if shock from the drug intoxication is suspected, type and cross match of the blood if hemorrhage is the cause, amylase and lipase for suspected pancreatitis, gram stain and culture for sepsis, tryptase and histamine level for suspected anaphylaxis, peripheral smear for suspected malaria, cortisol level or corticotropin stimulation test for suspected adrenal crisis, and thyroid function test for suspected myxedema coma. Imaging helps in undifferentiated shock. With regards to chest radiography, pneumonia helps in diagnosing septic shock, pneumothorax helps in diagnosing obstructive shock, the presence of pulmonary edema helps in diagnosing cardiogenic shock, and the presence of widened mediastinum helps in diagnosing aortic dissection. The free air under the diaphragm suggests viscous perforation, and other imaging tests should be directed at the etiology of the shock. One of the tests which is important and very relevant to the care of the shock patient includes point of the care ultrasonography. Point of care ultrasonography is bedside diagnostic tool in patient with the undifferentiated shock and hypotension. Not all patient in shock needs point of care ultrasonography. It is typically used in patient in whom an empiric diagnosis has not been achieved with clinical and the laboratory evaluation. It is also useful in those in whom definitive imaging is unsafe. The other use of point of care ultrasonography is as a complementary tool to assess the fluid responsiveness in critically ill patients. The first view in point of care ultrasonography is limited view of heart, and here pericardium, left and the right ventricle and IVC is being evaluated. In pericardium, it is looked for the pericardial effusion, and if the chamber collapses and there is reciprocal changes in the right and the left ventricle during respiration, it supports the diagnosis of tamponade as a cause of shock. In left and the right ventricle, it is looked for the contractility and the size of the ventricle. A floating thrombus in the right atrium and the ventricle suggests pulmonary embolism. Inferior vena cava is looked for the collapsibility at the end of expiration, and it suggests hypovolemia from the hemorrhage or non-hemorrhagic causes. A dilated inferior vena cava may support the diagnosis of cardiac tamponade or pulmonary embolism. The subsequent view in point of care ultrasonography is view of chest and abdomen. Here, lung and pleural space and parietal cavity is being evaluated. The absence of lung sliding indicates pneumothorax. Pulmonary edema is suggested by the presence of B lines and it supports the diagnosis of either primary pump failure or volume overload subsequent to fluid resuscitation. A pleural effusion supports the diagnosis of empyema or hemothorax. In peritoneal cavity, evidence of significant peritoneal fluid accumulation suggests the diagnosis of blood loss in trauma or a potential source of infection. The last view in point of care ultrasonography is view of vascular structure and it includes aorta and proximal lower extremity veins. In aorta, it may detect a thoracic or abdominal aneurysm or an intimal flap consistent with the dissection of aorta, while in proximal lower extremity veins, lack of compressibility suggests DVT, thereby raising the suspicion for pulmonary embolism. In terms of advantages of point of care ultrasonography, it is portable device, inexpensive and does not expose the patient to ionizing radiation. Rapid examination of multiple organs is possible with this machine or device. Additional advantages include the targeted application of life-saving therapies like pericardial drainage, chest tube insertion, peritoneal drainage, and the safe performance of the vascular access procedure. Another advantage include serial imaging to follow the therapeutic response to intervention can be done and to detect the procedural complications. In terms of disadvantages, it has limited sensitivity for many of the etiologies associated with shock. For example, if the patient has hyperdynamic small cardiac chamber, it cannot differentiate whether it is due to hypovolemia or it is because of sepsis. So, in summary, clinical suspicion is critical for the diagnosis of shock state, followed by bedside and the laboratory evaluation. Point of care ultrasonography is required when diagnosis is not reached on the basis of bedside and the laboratory evaluation. Hope you like this video. If you have any feedback, suggestion or comments, please write down in the comment section box and please do not forget to subscribe to my channel. Once again, thanks for watching this video.